for the proper chemotherapy to give, because when we give intravenous chemotherapy, there is 5-year survival of 66 months, which is beyond any systemic chemotherapy, but 40% only of the patient develop this, because the chemotherapy, when given intravenous, it causes much toxicity and much complication that we search for the proper chemotherapy to give in intravenous. And I have ovarian session, I will tell that. So in ovary, the story is not like chemorectal or subglutocoprid or something. In subglutocoprid, the hybrid is a very promising, but in ovary, the systemic chemotherapy may be as good as a hybrid or even better and less beyond less toxicity and less morbidity. Can you agree with that?
I said at the beginning that the standard in this operation in the pseudomyxoma peritoneali, then the colorectal, and the ovarian is questionable.
Because there is an alternative.
Yes, but some of these cases, or almost half of these cases, were failed much 2 or 3 lines of chemotherapy.
This is its part.
Yeah, and we tried.
As a standard.
Maybe.
I'd like دكتور جمال ممتاز انك انت تعرض الحالات وانها numbers of cases few, but we have a feeling that the complication is so much high. So by practice, I think the complication rate might be reduced by avoiding certain factors that increase toxicity or cause of death. We can improve the procedure. But I need to know from these 18 patients, what about the prognostic factors of the tumor itself? You didn't tell about the grades, mucinous or serous, other factors as regards the tumor. We should know these prognostic factors, because these factors may have a positive impact rather than the procedure itself. This first one. Second, you have mentioned some of the chemotherapeutic drugs that can be given intraperitoneal. And as a medical oncologist, I think there should be a caution about selection of the active drug by itself, and not to be activated by the liver enzymes or something like that. For example, intraperitoneal adramycin or mitomycin, if it can be accepted for intravesical instillation, I think after surgery and there is a wound and there is a raw tissue or exposed tissue, and the exposure of this chemotherapy may increase the rate of complication, especially fistula or tissue damage. So we would be very cautious about using of such a drug. So oxaliplatin, that the standard we use now, by giving it systemically, I think it can reach every part in the body through the vessel. But giving intraperitoneal chemotherapy, large molecules, the rationale of giving this intraperitoneal large molecule is to stay a longer time to the area that needs to be controlled. So not to increase the rate of washout from the peritoneum. I need to keep this drug for a longer time to be active. So I select a large molecule, cannot be absorbed easily through the vessel. Otherwise, if I'm encouraging these drugs to be washed away, so why I use it intraperitoneal? I can use it intravenously instead.
First of all, I agree with you that the complications at the beginning were so much, because we used to do anything referred to us from the chemotherapy department. but now we select cases and we don't do the much heroic surgery as before. So we get in the last year much less complications. And the other thing is that we don't select the chemotherapy. We send the cases to your department, and they tell us the drug should be so and so, and we do this.
But with this still in a clinical trial, within a context of clinical, it's not the standard.
The other thing is that I didn't mean here I am only now explaining the surgery and the steps and the technique and the complications. I didn't go through survival. Even I calculated the survival roughly some patient living, some died, some recurrence, but I didn't do statistics, and I haven't gone yet through the statistical and the relations between different factors and survival.
Dr. Gamal, I think in colorectal cancer, you shouldn't use this technique unless the patient has segment ring differentiation with peritoneal carcinomatosis and the KRAS positive.
It's not necessary,
but you should use it in such situations.
I agree with you, Dr. Amr, that chemotherapy, ovarian cancer, the situation is different from peritoneal carcinomatosis from the colon or So this is a special, separate category, but the ovarian cancer itself, in order to be managed in such an aggressive manner by surgery, in the presence of another many chemotherapies that might be effective and prolong the survival, I think we have to balance the toxicity versus the efficacy.
I have a question about when you remember 10 years ago, I was the first to installate intraperitoneal chemotherapy in intractable ascites patient. I had 25 cases and my result was very encouraging. But anyhow, I know how they do believe now that the ideal intraperitoneal chemotherapy is not yet developed. They do intraperitoneal subtype of Avastin or subtype which stay in the peritoneum, like you said. And the whole issue of intraperitoneal instead therapy is that you give the drug to stay more in the peritoneum and absorb about 1/3 of its systemic, and it even acts like the metronomic chemotherapy. It prolongs its survival. This is the mainstay of intraperitoneal. There is some set of chemotherapeutic now only for intraperitoneal use, instead in phase 1 or phase 2 trial.
Thank you. For advanced ovarian carcinoma stages 3 and 4, have you tried neoadjuvant chemo before surgery, or you just gone for upfront surgery?
I made something like a table. I said some cases with not properly treated before, some cases with who received adjuvant, and some cases which received neoadjuvant.
Oh, very good, because if it comes after neoadjuvant, I think the picture would be different from some of these.
Received neoadjuvant.
Some receive, and this is the picture after the neoadjuvant, so still they have...
No. This is the cases...
with the upfront surgery.
Yeah.
With the upfront surgery. This one...
The cases with neoadjuvant, as I said, I did 2 cases in January, this January.
Yes.
This received neoadjuvant, the picture was different.
Absolutely.
Even I didn't do the whole peritoneectomy in some cases, and I didn't remove the spleen in one case. The disease was less. But some cases also which received neoadjuvant chemotherapy did not have any response.
Absolutely, because in many patients we opened as exploration in the first instance, but we couldn't do anything rather than biopsy. We referred to chemo, and then we followed up about 30 patients. In the other 15 cases, about 50%, you can do the interval debulking to the optimum point and be very happy. You don't need to do upper abdominal surgery because we don't know. We don't remove the spleen, we don't strip the diaphragm, and all this heroic surgery that we are not experienced in, and we don't do. So in 15%, absolutely you can go. You would be lucky to do a standard cytoreductive surgery to the optimal point of view. And the other 15%, there was no significant change, and we couldn't even proceed. We asked our colleagues from surgical oncology to help on, but I would say the prognosis was not good at all, and the morbidity and the mortality was much higher than we said. So you should be congratulated for this heroic surgery and good prognosis so far. And this 15%, the mortality was about 50% again. So it's not an easy disease.
No.
Thank you very much for a nice talk. I have to mention that I think that the intraperitoneal chemotherapy will have a definite role in recurrent cases of cancer ovary. I remember I had a case of stage 3 cancer ovary, and proper debulking was done as much as possible. And after 1 year, recurrence occurred in the inside the wound, and some deposits were found. And I opened the patient, and we have I instilled a protocol for intraperitoneal chemotherapy, and Professor Walid can tell us about his what he did for this patient. Now I think she's living for 3 years now. More than 3 years after the second second surgery, and the effect is very good, and the general condition of the patient is very good. She's going.
Both systemic and intraperitoneal. This is a combination of systemic and intraperitoneal. Yeah.
But still, you give systemic and intraperitoneal in the same time. Yes. Okay.
And the result of both systemic and intraperitoneal is the highest.
It's very good.
In ovary.
And the patient is tolerating very well the treatment, and she's traveling and going around, and everything looks to be.
With surgery or in second? How you put the rooms in? Through surgery or?
Surgery, open surgery.
There's a comment.
I just want to ask about the case of ovarian cancer, which received neoadjuvant therapy. Sometimes we don't have response, as Dr. Said said. In our center, I'm from Mansoura Oncology Center, Mansoura University. We do believe that primary upfront surgery is the best for ovarian cancer, especially in advanced cases. We try to do optimal debulking from the start. But sometimes we receive cases that have received neoadjuvant therapy and there is no response. My question is that we do believe that the aggressive tumor, which doesn't respond to the chemotherapy, doesn't respond or will not have good prognosis even after surgery. So would you encourage us to try to do maximal site reduction and optimal site reduction for far advanced, and you know, when surgical oncologists say far advanced cases of ovarian cancer not responding to chemotherapy, would be a benefit for some patients or not?
I think the condition is not settled for these cases, advanced cases, where to start first with chemotherapy or to do staging laparotomy and do maximum debulking surgery. I think if there is massive ascites, I think you should first induce chemotherapy.
Debate.
I think. Maybe
there is a comparative study of even primary and deferred chemotherapy, and the result is comparable.
No difference.
For primary ovarian cancer, the EORTC trial by Vergote et al. Showed no difference in outcome. However, there's a push, particularly by some surgeons in the USA that have high volume workloads for aggressive surgery, that they think the patients are still dealt with much better if you can do your maximal cytoreduction as your primary treatment. So they will go in and do the massive surgery that we've heard about, supraradical surgery, stripping the diaphragm, stripping the peritoneum, splenectomies, etc., to get down to zero residual disease at the end. And their belief is that the trials, the EORTC trial, that this type of surgery wasn't included routinely, and therefore you're not going to see a difference between the two arms. That they think that by giving neoadjuvant chemotherapy first, that you're going to be left with tumour-resistant groups of cells left in, and so these patients are not going to do as well later because you've given these tumour-resistant cells more time to grow. But the second point about the HIPEC, Professor Secretary and myself will work at one of the two registered places in the UK for HIPEC. And at the Christie, we take all of the cases for the north of England. At present, they don't think there's enough evidence to use this with ovarian cancer at the moment. Even in recurrent cases, we believe that anything for ovarian cancer should be included as part of a national or international trial at the moment, and there's nothing that we're involved with at the moment. The UK, the NHS won't fund us for ovarian cancer for HIPEC. However, I think these patients will, there will be definitely a group that will do very well because of the surgery itself that's being undertaken to aggressively remove it all. And unfortunately, you won't know whether your results are so good because of the surgery, because of the HIPEC, or a combination of the two for the moment, I think.
That's true, and the good thing is that you're documenting everything, Prof. Gamal, so we can build up on that and maybe complement this by having another arm whereby we can then control or do a control trial for these. The issue about those who do not...
combination of HIPEC plus...
systemic or HIPEC only or the systemic only?
There is now the invasion of beta. Bevacizumab now in these cases. There is an invasion.
And we actually have a good workload and volume of cases, we can do that.
I think that the guys at Memorial Sloan Kettering will say, this is Dennis Chi and Doug Levine who are doing a lot of the big surgery, is that if you can get down to zero residual disease, it will be much better benefit than anything bevacizumab will give you, which is only a matter of a few months and much more expensive to the patient, the government.
I will say that in my talk.
Absolutely. The bevacizumab sometimes is being viewed as an excuse for leaving chunky disease, which shouldn't be the case. I just want to, before I give the last comment to Professor Gamal Amira, some of the low-grade ovarian cancers, the low-grade ones who are not very responsive to chemotherapy, and when they are advanced, usually they are advanced regional, disease in the pelvis. But some of them, I've seen it, actually have omental disease, diaphragmatic disease, and all this, and those are the ones that actually it could be justified to do heroic surgery for them, because whatever residual disease left might not respond very well for chemotherapy. And it happened that we did that, and we did, colectomies and all this for these low-grade cancers. So always consider that in the low-grade ones. Professor?
I have a comment for your question, a final comment, is that the rule is if the disease is still peritoneal, whatever large or extensive or involving the peritoneum and serosal surfaces only, and you leave the minimum residual less than 1 centimeter, are the cases which respond. But the cases which you do maximum debulking and you leave tumor more than 1 or 2 centimeter, whatever you do, you will not going to achieve a cure. This is a type of palliative surgery anyway.
Just a small question on the comment you just mentioned. Would you think it's wise for patients who are low grade, and we know most probably they will not be very responsive? Would it be like to go for HIPEC and extensive excision without the weight of chemotherapy trial before? I mean, as a primary approach.
The justification is the known fact that it depends, your survival duration depends on the amount of residual disease. So in those cases, when you do your surgery, you aim to leave zero residual disease because you know that they are not very responsive to chemotherapy. But you do not need a trial as such in that, although a trial to assess any hypothesis is a good thing to do. But in those cases, just you're adopting the standard approach to ovarian cancer, which is aiming for zero residual disease, and if you're leaving a residual disease, has to be less than 1 centimeter.
What I meant is not getting an experience, but an experiment. I meant you go immediately on first presentation on extensive surgery without giving the chance or giving them 1 or 2 cycles of chemotherapy to be sure if they have a suspending or not. Since in any way, if they will be resistant, most probably you will lose some time with more extensive disease than it was extensive on the beginning. So if you know that most probably they will not be responsive, you might go now because it will be easier, relatively easier than later.
Yes.
Do you think this is wise?
Yes, there is no harm in trying new adjuvant chemotherapy in them, but what I meant is that when you decide to do the surgery and do the surgery, try to remove exactly, try to remove everything, because whatever you leave is not going to respond. Although there was one case that I remember that was a joint case and it was a private case of my colleague colorectal surgeon. You know how it is in the litigation in the private sector and all that. And she required kind of left hemi colectomy to remove a small area that was left, and he didn't want to do either segmental or a left hemi colectomy, so let's leave it as it is. It was about 1.5 centimeters deposit. She had chemotherapy after that, and this area actually went calcified. So when we were following her up with CT, each time we do a CT, it's the same, and it becomes brighter, and it was calcified, and actually, until I went, it was fine, yes, exactly. So,
I think one of the things that deserves a clinical trial is for those patients to question the amount of residual acceptance. Because it's true that those patients are not responsive to chemotherapy as others. However, ironically enough, they don't grow as speedy as others. So if you can go for extensive surgery on the beginning, even if you leave a CC2 and not CC1, maybe, just maybe, we can find that this might not be very bad for those patients.
I agree. But if you can remove everything with a good surgery, just go for it.
Of course.
If you, for example, where would be a situation where you can't remove residual?
I mean, it's about that when you think that you'll not be able, you will not try, and you close the patient, and most probably the patient lost even the benefit of doubt. So I meant in those patients, you might go, even if you're going to leave more than the CC1, just slightly more, and try systemic therapy. Most probably it won't be worse than closing it as it is, because you won't respond to anything.
But that shouldn't be the intention.
Yes, I know.
Thank you. I think we are close this session.